Our area of research focuses on the management of patients with heart failure, and we have a pair of studies that were just presented looking at, in particular, something that we've really focused on in our research group, which is the use of biomarker testing for understanding heart failure and how to better manage it. Biomarkers are circulating substances in the blood that help physicians to better understand the diagnosis of heart failure in our patients. And we've been both involved in studies of established biomarkers but also emerging ones. And the studies that we presented today are looking at a very new biomarker called IGFBP7. It's a long name, but the interesting thing about this biomarker is that we found that it is specific for something called diastolic dysfunction, which is a pathologic process that is particularly problematic in patients with heart failure and preserved ejection fraction, which accounts for half of the patients with the diagnosis of heart failure. The key here is that heart failure with preserved ejection fraction has no defined therapy. We've seen several studies at the meetings here that were neutral or frankly negative for treatments for HFpEF. And so many of us are starting to believe that the way to look at patients with the diagnosis is on a more fundamental biological level. And this marker, IGFBP7, we found is quite prognostic in patients with heart failure with preserved EF, and it is very specific for the basic pathophysiologic mechanism of heart failure, that is diastolic dysfunction. This is a very novel finding. There are no biomarkers like this that exist, and so this could very well be the key to unlock specific therapies for this diagnosis. We stumbled across IGFBP7 after doing proteomics screens. So basically what we did was we looked at concentrations of various biomarkers in the bloodstream of patients with heart failure and identified specific candidates that that appeared to be promising with respect to their ability to predict something called ventricular remodeling, which is the change in the heart muscle that occurs over time in patients with heart failure that is a bad thing. We then took those results and went to humans and looked at concentrations of IGFBP7 as well as several other markers and found that while IGFBP7 does not in fact predict remodeling, it was very tightly associated with these diastolic abnormalities. We then went back to the bench to animal models to actually look at what happens when you interrupt the gene for IGFBP7 in laboratory animals, and we found, in fact, that these animals are uniquely resistant to heart failure onset, which really suggests that this is a key player in the pathophysiology of heart failure. It changes the diagnosis in the sense that we are attached to the concept appropriately of using clinical means to make the diagnosis of any disease. The problem is with heart failure, it's really not a disease, it's a mixture of syndromes. Some patients have an identical appearance, medically speaking, but if you look at their underlying cardiac structure and function, they're very different. So using markers helps us to more accurately sort out patients on a more objective level. And the hope would be, and this remains to be proven, identify opportunities for therapy intervention that are unique to those specific patient types. And again, I'll reiterate that we and others have looked for treatments for HFpEF, heart failure with preserved EF, and haven't been able to find them in large populations. So now we have to take a step back and ask the question, should we be looking in a more objective way to identify individuals that all have this specific trait, an elevated IGFBP7, for example, and treat them specifically rather than the group as a whole who all have a preserved EF but may have very different reasons for their heart failure. Biomarkers have the advantage of being widely available once they are produced and verified. So the example that we give for this exact concern is the now widespread availability worldwide for the markers BNP and NT-proBNP. These are natriuretic peptides. We did the first US-based studies at the Mass General Hospital for NT-proBNP, actually, at a time when very few hospitals were running the test clinically. Now, every hospital in the United States of America runs these tests. You can find them internationally in third world countries. So it really is reasonable to expect that with further development and perfection of these assays, they'll be more widely available. We're looking in larger data sets to confirm our findings for this new biomarker. The assay itself has already been perfected into an automated version, so we can run larger numbers of samples much quicker. It's still research use only, but we are planning on expanding into other data sets to also look for treatment opportunities. In the basic science world, we're also looking at the underlying molecular mechanisms that explain why IGFBP7 does what it does, to see if we can identify other techniques to potentially address this, including manipulation of different medications and other means to interrupt the IGFBP7 cascade.